Hey everybody, just a reminder, we're gonna have our cameras on during the lecture so people can know who's asking questions and stuff.
All right, everyone. I've been given the go ahead to start for today. So, good morning, everyone. I'm gonna share my screen and pull up a presentation. If you have some kind of note taking, like if you're gonna take notes on paper or on your computer, I'll get that ready now. And then Hannah and Mac, I'm not gonna be able to see like things that come up in the chat and stuff. So could you like deal with those or relay them to me, please?
Mm-hmm.
Okay, thanks. Okay, so today we are going to be talking about the economics of Medicare for All, um, a functionally single payer system that's been introduced by progressive candidates, most notably Bernie Sanders. So I'm actually going to start off today talking about the ACA, Obamacare, the Affordable Care Act as well. But also just hello, I'm Tyler. I'm a co-leader of the Novice Policy Lab. I'm a coach at George Mason as well, and I've been working the GMDI for a few years. But okay, let's jump in. So the Affordable Care Act, full name, PPACA, Patient Protection and Affordable Care Act, or Obamacare. So the ACA was passed pretty early on in Obama's first term. It actually went into effect in the fall of 2010 and is probably the biggest piece of single legislation within the last decade, I'd say. And it had a lot of fundamental changes to how our healthcare system operated before that. So I'm going to go over a few of the most major changes for how the ACA restructured paying for healthcare. It did a lot of things, but I think these are some of the main ones. Okay, so first is that it set up insurance exchanges for individual coverage. So before the ACA, there was no single marketplace for you to be able to go and choose and compare different health insurance schemes to see which one was the best, which was the most affordable, which one just worked with how you wanted to pay for healthcare and which covered the kind of things that you wanted covered. So the ACA set up healthcare.gov. So state-based exchanges, a marketplace where you could go and search for those kinds of things. So the fundamental idea was that if you increase competition, when insurers are more directly providing different services to you than compare, it's going to bring down overall costs of healthcare. And in fact, the ACA was originally designed to include a public option health insurance scheme where the government would also provide a public insurance option, similar to Medicare, but for anyone to purchase who could pay into that, which would compete with the private insurance companies. That was scrapped during the while they were negotiating the details of the bill. But the fundamental principle of the ACA was to increase competition between insurers, which we can already see is a pretty big difference from what we're going to be discussing more, just Medicare for all, which is to have a single payer system, one big insurance company that's going to provide healthcare for all or nearly all of Americans. So next is that the ACA established what's called the individual mandate. So what that means is that it imposed a a penalty on your taxes if you were an individual who did not purchase health insurance. And the idea of that goes back to the idea of health insurance at its core, right? That in order for insurance to be sustainable, for you to have a big enough pool of resources for people to dip into, that means that healthy people who aren't going to be using those services as much are going need to be ones who are paying into the system, right? So this is how it works for any insurance scheme ever. So let's say, for example, that there's an insurance company that has 2 people enrolled. It's got me and it's got Hannah, and we pay $2,000 each into the health insurance or into the insurance scheme. Let's say this is a car insurance company, and then we both wreck our cars, right? Now the pool of money that we can dip into is only $4,000, which is not going to cover all of the expenses that we need. So that insurance company has now failed. What you need is people, let's say Mac, to also join in the health insurance company, and Mac is not going to wreck his car. He's going to add in to the pool of resources to help other people pay. So the individual mandate was financially incentivizing people, well, or really just imposing a penalty if they didn't do this, so that you could increase the number of people in the insurance pool. Okay. Next is that it required businesses with more than 50 employees to offer health insurance to companies. So if you're a business of a certain size, that is something that you were now obligated to do. The majority of health insurance like coverage in this country does come from employer-based health insurance. But this reduced the number. This set the number at 50, which is a little bit of a smaller number than a lot of companies have employees, so that overall employer-based health insurance could cover even more of the population. Next is that it set national standards for insurance plans. So this included the goal was to eliminate insurance plans that were, let's just say, trash. They didn't actually provide a lot of necessary things that when you get really sick or injured, you would expect that your health insurance provider would help you cover. So those kinds of insurance plans are called bare bones or catastrophic coverage plans. The ACA said that you needed to meet national standards in order to be involved in the you needed to, your insurance plan that you were offering needed to meet that standard, as well as a capped out-of-pocket costs to keep costs down for consumers, to protect them in the event of major health crises or ongoing health crises. Next, it increased subsidies for lower income people to help pay their medical expenses. So the way that government subsidized, the way that government helps you pay for insurance, was largely limited to the 2 biggest federal programs, Medicare and Medicaid, well, federal and state programs, Medicare and Medicaid. But with the establishment of the exchanges, when you applied to enroll for coverage through the Affordable Care Act, the government would now give you financial assistance to help you do that, which wasn't the case before. And the last big thing that I want to cover, that I'm actually going to talk a little bit more about in a second, is that it worked with states to expand their Medicaid programs. The Medicaid just as a refresher, is a government-provided health insurance option for poorer or lower income or disabled individuals to help pay for their healthcare expenses. So the ACA had initially planned to help cover an expansion of who is eligible for Medicaid. So right now, each state has a certain number. If you make 30% of the federal poverty line, if you make 50% of the federal poverty line, something like that, you qualify for Medicaid. The ACA was going to expand that to be 133 or 138% of the federal poverty line, and then have subsidies for people who made above that up to 400% of the federal poverty line. So basically 133 or 38%, you would qualify for Medicaid. Anything more than that, up to what the government, like the ACA, established to be a substantial enough income for you to be able to pay for your own private insurance, they would help subsidize that portion. Okay, so that was what the ACA established when it went into effect into 2010. However, that was a while ago, and there have been some significant changes in the courts and under the current administration. So first, in his first year in office, Trump effectively repealed the individual mandate, which meant that individuals are no longer penalized as much for not providing health insurance. There are still studies to see about what the effect of the original individual mandate was and what the effect of the change has been. But ultimately, it is probably taking people out of the insurance pool who would otherwise be compelled, otherwise, or because of a tax penalty. Next is that it changed the insurance plans that businesses were allowed to offer. If you see on the next bullet point, they had to meet national standards. Businesses of that side no longer necessarily have to provide insurance plans that meet that standard. So you could technically get coverage from your employer, but it could be really bad and not actually help you when you need medical assistance. Next is that, and this is what I'm going to talk about next, is that the courts decided that compelling states to expand what individuals would be eligible for Medicaid, that was struck down by the Supreme Court in 2012. So it then defaulted to states opting in or denying the expansion of Medicaid. What this meant was that the federal government was offering money, slowly phased out over the next however many years, but initially 100%. The federal government was offering money to help pay for lower income and disabled individuals in your state. And the state governors, a lot of them said, no, we don't want that money to cover, to expand Medicaid, get more people involved in that program. So what happened was that a lot of states, I think now it's still some more states have opted in, but I think it's 14 states still haven't expanded their Medicaid programs, which means that there are people who fall into what's called a coverage, where they don't apply for either Medicaid or the subsidies provided by the ACA if you're making 133% of the federal poverty level. I have a graph to show you what that looks like. So at the bottom, you can see on the left, you can see the blue area, which is what states have set their Medicaid eligibility limit at. Then you have no coverage, which is the gap between what the ACA said it would subsidize and what the state's Medicaid eligibility requirement is. So people in that gap neither get subsidies nor Medicaid, and have no health coverage. Okay. If you have questions about that at the end, let me know. But that's really how, in a lot of this country, healthcare is provided through the government, and what the role of the federal government and the states paying for certain healthcare programs looks like. So now we're going to jump to hello.
Can you go back one slide real quick? Please?
Sure.
Thank you so much.
Yeah. So this slide I just put in red and orange parts of the ACA that have been rolled back or watered down since its enactment.
Okay, thank you.
Sure. And I'll send this to Hannah to upload into your folder or something. Am I okay to move on?
Yes.
Okay. Now we're going to talk about the actual proposal on the table for the PF topic, MFA, Medicare for All. Okay, so because health insurance is so faceted, there are lots of different moving parts for what health insurance looks like. In terms of its economics, you have individuals who are buying healthcare, individuals who are receiving government provided healthcare. There is the relationship insurers and their patients. There's the relationship between insurers and healthcare providers, so doctors and hospitals, and all the different ways that insurance or those medical services are paid for. So this there are a lot of moving parts to this, which may work in tandem or against each other. You might see good things happening for certain aspects of the economy as a result of a government healthcare system, and you might see negative effects in a different area. So we're going to talk about certain areas like that. Okay. So the first thing is jobs. There's definitely a divide on what kind of impact a single payer Medicare for All system would have on the job market. So in favor is that it would boost the actual wages and salaries of employees, because companies, as I mentioned earlier, companies or employer-based health insurance is the biggest single provider of health insurance for Americans. So when companies no longer have to pay to enroll their employees in an insurance company, they now can dedicate that money to other things, such as paying their workers more, right? Continuing to grow, expanding, opening a new franchise, all of that, because they are not on the hook for providing employer-based health insurance. Next is that it increases the job quality. This actually goes along with the second last point about job lock, which means that people no longer get a job because of the benefits, because they have better health insurance. They go to a job because they're good at that job, and for no other other things going on, right? So you might be hopefully gifted engineer, but working at an accounting firm just gives you better health insurance. Now you have the freedom to not worry about, oh no, if I quit my job at the accounting firm, I'm going to lose my good health insurance. Now you can actually go and do what you're best at. So it increases the overall quality of those people performing in their jobs. Next is that it supports entrepreneurs, self-employment, small businesses, for similar reasons, in that people have more freedom to pursue career opportunities and business growth opportunities when they don't have to worry about their own individual health, which you can make arguments for why like the development of smaller businesses and the growth of self-employed individuals can be a good thing for market competition, as opposed to, I just have to work for Amazon because Amazon, if I reach a certain level, will give me some benefits. Now you can have an alternative to Amazon because you don't need care from them. Okay. Next is that it lessens the economic shock of losing a job or moving between jobs. So when you lose a job, but you still have a medical problem, either an ongoing medical problem or you lose your job the next day, you get hit by a bus, you're having a really rough time. Sorry for you. But one thing that makes that exponentially worse is that now you don't have an insurance company to help you pay for your medical expenses, which makes it harder for you. Well, it makes it harder for you on a personal level, but it also hurts the economy because now you are not someone who can spend any money on anything else. You are not a person who can, like get a new house, get a new apartment. You're not someone who's going to have the freedom to start their own business because you're just hampered by the economic burden of losing your job and still being on the hook for medical expenses. So job lock, I've actually already covered this a little bit earlier. Goes pretty hand in hand with 2 and 3, and then also is that it produces job gains in the actual provision of healthcare. So, like, if more people can now go to the doctor, we're going to need more doctors. So presumably more doctors would be hired. So people with medical degrees who can't find a job anywhere will now be able to find a job pretty easily because there's such an increase in demand for their services. So arguments against the in-on jobs is that similar to the last point of the other one, that it increases jobs in hospitals. The actual tangible effect of a Medicare for all system is that it would eliminate the need for private insurance. There are going to be few, if any, people who are going to pay for a private insurance company when they can get that for free, right? So people who work at Aetna, at Blue Cross Blue Shield, who work at health insurance companies, will have to transition to another job because their job has functionally been made redundant by the federal government because it provides its own healthcare service. And some of those people who work in health insurance could find their job in the government-run insurance organization, but probably not everyone. The next is that it contributes to what's called a brain drain effect, but in reverse. So brain drain is the concept that when you have a high-paying labor market, people from other countries are going to want to come to your country because you are giving them the opportunity to earn more money. So right now, because of the privatized system of healthcare in America, a lot of doctors from other places who would be getting government salaries come here to potentially get more money because the profits are higher. So the argument against Medicare for all is that we would see a reverse of that effect, that when healthcare becomes nationalized, you are going to see people leaving the country or no longer coming to the country because they think that they can earn more money elsewhere. Would it be bad for our economy because we would no longer have as many high-paid, skilled jobs, especially in the medical profession here. Okay, next is that it would shrink the available public funding for jobs.
Hey, Tyler, we have a question.
Go ahead.
Yeah, so would that reverse brain drain affect what kinds of professions, just mainly the healthcare workers would want to leave the country or other um, you know, employers?
We'll get to other employers a little bit later, but this is specifically talking about like doctors, right? Like
Okay.
healthcare professionals. I mean, the healthcare industry is pretty large, so I don't know all of the effects on if a healthcare administrator really comes to the U.S. because those jobs are higher paying. It seems likely though because of the amount of money poured into the healthcare system here. So, okay. So next point is that it shrinks available public funding, which is like the government paying for uh, certain sectors, which is also a significant provider of jobs. So when the government has to pay more doctors and more nurses, maybe they can't pay any mailmen, or maybe they can't pay as many like garbage collectors or whatever, like or teachers or administrators, right? They can't work for people with they can't pay for as many people in the public sector because those costs have been allocated towards healthcare. Okay. So the next is in the actual provision of healthcare. So what actually happens at hospitals and with doctors and with pharmaceutical companies? What is the effect of Medicare for all on how those things get paid for? So the biggest argument that Medicare for all supporters will cite is that when the government becomes the single payer, when all healthcare providers, hospitals, doctors, go to the government for money because they provided a service they're going to get paid. The government can negotiate down the costs of what it will pay, either in terms of like hospital like service fees. So if a hospital was charging an insurance company like $20,000 to use an MRI machine, the government could then say, you actually don't need $20,000 to run an MRI machine. We're going to pay you $15,000 to run the MRI machine, and since you really can't go to anyone else to pay you, we actually have a lot more leverage negotiating down the costs of what those services, of the cost of those services. Similar for prescription drugs. When you get a prescription drug, when you have to pay for prescription drugs, that would potentially be provided by like Medicare for all. So the government could go to pharmaceutical companies and say, like, hey, you can't charge $10,000 per pill for a life-saving drug, and so it bring the cost down in that way. On the flip side is that the actual landscape of what hospitals look like would be significantly changed by that payment system. So when hospitals and doctors don't think that they're going to get paid as much to provide a service, to use something, to give you certain medical supplies, they're going to want to ration those services. They're going to err against giving you some kind of treatment or pill or something, because they're not going to be able to cover the costs of doing that for everyone. Similarly, for doctors, hospitals that have their revenues decrease because they're receiving less money may not be able to hire as many doctors. So even as we said before, in the job market, more demand because more people who have been delaying going to the doctor because they don't have insurance, that might increase the need for doctors. But on the flip side, maybe the hospital can't pay those doctors. So that's a balance. And then also, just like what I was saying, is it encouraged increased doctor visits. So people may not go, people will go to the doctor for things they may not previously have gone to them for, but that may not be always necessary. And you could go for like silly things like, oh, I have a headache, I need to see a specialist in neurology, and that might not be necessary. And it would cause extended wait times for appointments, drain resources, all that. I think we have a couple of questions. Am I hearing that right? Or a couple of dings?
No, sorry, Hannah was messaging us.
Oh, well, Hannah ruined everything as usual. Okay. Moving on. So administrative savings, this may only look like a single bullet point, but it actually accounts for a very outsized portion of healthcare in this country. So there are estimates between 25 and 50% of every dollar spent on healthcare actually just goes to filling out the paperwork and to going through the bureaucracy, administering the billing. All of those things actually account for potentially as much or nearly as much as the actual cost of healthcare. So the argument in favor of Medicare for all is that once you do that, there's only one insurance company, right? The federal government. So it really cuts down on all the differences between how insurance companies pay healthcare providers, because there's only one. There's only, like, you don't have to go through like, hey, Aetna charges hospital X this amount, but Blue Cross Blue Shield, a different insurance company, charges hospital X a different amount. We need to figure out how much everybody is getting paid because all of the rates are different. So there's evidence provided by the current existence of Medicare, which covers elderly Americans, that the administrative savings of Medicare are much, much lower than private insurance companies. So Medicare actually has an estimated 2% of costs dedicated to administration, whereas private insurance has, like I said, those estimates on average 25 to 50%. So Medicare for all, a lot on the actual administration. Yeah, and I can go into that a little bit more, but it is just kind of a weird and complex thing that if I'm on insurance plan 1 and Mac is on insurance plan 2, and we both like lose our kneecap for some reason, depending on my plan, I could pay my insurance company $10 and the insurance company pays the hospital $20. But Mac could pay the insurance company $30 and the insurance company pays the hospital $500. All of those rates are just wildly different and hard to sort through. So keeping it all centralized would reduce that complexity. And then the argument against that is that it's a lie, that administration does not actually account for the reasons that healthcare costs are growing, such as an aging population, more obesity. I'm sure the pandemic probably plays a role, that healthcare costs are probably going to increase regardless. And then there's just also people who don't think that the government is an efficient or effective provider of services generally, and in addition to healthcare. Okay. So the next thing is taxes. So the arguments in favor of a Medicare for all system is that individuals already pay a lot of money in various forms for healthcare, right? So even if a Medicare for all bill would increase taxes, that's money that's already being spent elsewhere in a number of areas. So one, you have to pay your premium, just like how you subscribe, for lack of a better word, to an insurance company every month. You have to pay a co-payment, just a fixed rate to see a doctor or to get a certain drug. You have in your insurance plan, you'll have a deductible, which means that you are accountable for paying the first $2,000, $3,000, $4,000 of your medical bills before your insurance starts to cover anything. So all of those expenses really pile up, and the resulting tax increase of a Medicare for All bill might not actually increase the total amount of money spent by people. Even if you get a bigger tax bill, you're probably going to get a lower or a non-existent medical bill. So that's what proponents would say. And then also, it provides a more efficient system for, like I said, there's definitely an issue of the population aging in this country, which means that the government is going to have to provide healthcare for an increased portion of the population anyway, right? So the people enrolled in Medicare, that number is going to expand regardless, right? So you might as well increase the pool of the people in the Medicare system to create a bigger, more efficient system for people who are going to get health care from the government anyway. So next is that it adds, next is a lot of people will just cite the negative impact that tax increases generally have on economic growth, or GDP, gross domestic product, just like the measurement of a country's economy, one metric. So when those kind of taxes increase, like I mentioned before, the public sector, so government-sponsored industries, are going to suffer. That means that the government can't provide stimulus, can't provide economic incentives to private companies, won't be able to provide as many tax breaks for certain things because they need things for Medicare for All, which means that ultimately the private sector and the growth of industry is going to slow because the amount of taxes owed is going to increase. And then also is that it might trigger migration, so people who no longer want to pay an outsized tax rate, they can get bigger tax relief, and in other countries they might move themselves and their businesses to other countries, which overall means we get zero revenue from the taxes of that individual or business, right? So yeah, the question of taxes and the actual specific amounts of what could actually be covered feasibly by, say, an increase of taxes on the rich or a slight increase of taxes on the middle class is hard to evaluate, because in addition to how insurance companies operate, so Medicare for All would replace all insurance companies with one payer, there are different ways that payer could interact with other companies or with healthcare providers, which I can talk about at the end. So a proposal to be able to like reconcile all of those things sometimes gets muddled, because no one knows exactly how much money needs to go where in a hypothetical Medicare for All system. We don't know exactly how it's going to be run. Okay. And then I just added a few other things that didn't neatly fit into any categories before. I guess I have already mentioned the impact of medical debt. So when you no longer need to be paying off the expenses for when you had a serious illness 5 years ago, you can now be spending more money on other things, which helps grow the economy. And then just generally, when people have better access to healthcare, it means people are healthier, which means they're going to need to take fewer sick days, which means that there are going to be more folks on the job because they don't have an untreated chronic illness that they have to be dealing with while they're expected to work. So it's going to overall increase the productivity of workers at a company. And then argument against Medicare for All is that it would really rattle the confidence of businesses who now think that the government may impose additional regulations, and that wealthy individuals may now be afraid of an increased tax burden, which overall may not project the most amount of confidence in things like the stock market and for individual business plans when the government takes that role. Okay. So I'm actually going to pause there. Questions about what I've just covered. While I have about 12 minutes left. Does anyone have any questions?
Hi, I have a question about people moving or offshoring their taxes. Are
Sure.
there a lot of other places that have lower tax rates than the United States? I was under the impression that we were one of the lower tax rates in the world.
Yeah.
At least in the developed.
Yeah. So there are different. So there are a lot of things going on with that. So one is that there are of like developed economies. I think that's definitely true, but you still see a lot of like other countries. Like you see people like offshoring, like where else, like the Cayman Islands or wherever, Switzerland, or I'm actually not sure what the tax situation is there. So there definitely could be places that, even though it might not be the most conducive right now for businesses, there would be now an incentive to move there just because of the profits you would make on alleviating the tax burden. And second is that you could also incentivize countries to provide their own incentives so that they could poach American businesses, right? So now Australia looks at the US and say like, "Ooh, hey, maybe a lot of businesses there don't really like what's going on. We're going to maybe say that you're not going to have to pay as much for the provision of healthcare or for whatever it is, if you come to Australia, right?" So yeah, I think that's good.
I have a follow-up question to that.
Sure.
Is there like a certain industry that would be particularly susceptible to like continued offshore offshore?
You mean like right now or as a result of Medicare for All?
Either, I guess.
Okay. So I don't know right now what businesses are continuing to offshore. I guess tech companies and manufacturing companies, that's been on an increase. But in terms of like how Medicare for All would cause people to relocate, it really depends on the plan that would be in place, right? So if you're an individual, if you're like a really wealthy individual, you're going to look at what tax increase that you would get, and you would evaluate whether or not that is enough of a reason for you to move yourself or your business elsewhere. So I can't really speak to industries broadly because it depends what plan we're considering and what in those industries the breaking point would be, which I just couldn't tell you. I'm sorry.
Okay.
Anyone else? Okay, I have a couple more things that I just wanted to tack on to the end about different financing systems uh, for uh, for the provision of healthcare or for health insurance. So, like I was mentioning before, there are a lot there. Even if private insurance companies are replaced by a single payer, that single payer might have different approaches to how it pays for healthcare. And some of these that are listed here have been experimented with to some degree in certain federal programs or for statewide insurance schemes. So the first kind of like general section of like how healthcare could be paid for can be divided into two broader categories, although all proposals are a hybrid of the two. So first is value-based care versus fee-for-service. So fee-for-service is the dominant payment structure that occurs in the U.S. right now, and that simply means that when you go to a hospital, that hospital bills you for all of the things that it does, right? So you go in, you have a broken arm, they need to scan it, they need to put you on painkillers, they need like a nurse to check in with you, you need to stay overnight or something. Like each one of those things has a certain cost, and you are then your insurance company, if you are insured, then billed for each of those things. So there are different models for that that say that healthcare providers will receive money not based on just the amount of services that they provide, right? But how your health actually improved, right? So there you come in with a like a broken arm or something. The doctor might order like a lot of things, but if at the end of the day your arm isn't fixed, um, is it really fair for you or your insurance company to pay for all of the things um, that that were provided for but like by the doctor? So value-based care would, or a pay for performance kind of structure would really change the landscape of, or really change how doctors would be provided, so that the focus is now on doctors doing everything that they can to make sure that you are better, as opposed to doing as many different things that they can bill you for to help fix you. And I don't want to make it seem like I think that like doctors are like inherently like greedy people or something like that. Obviously, right now they are very important in dealing with like a global pandemic and putting themselves on the front line and all of that. But a lot of times it's not going to be up to them. It's going to be up to their departments. It's going to be up to um, like certain standards that evolve over time into what medical practices like are best for treating a certain thing. And then also just like the flip side of that is that do you would probably prefer that your doctor was more thorough in ordering more tests and ordering more procedures to make sure that you are the best, rather than them holding back and maybe not doing everything that they can because they want to keep costs down, right? So there's a balance between those two that I don't think has really been perfected here or probably anywhere in the world. Yeah, in like a robust, like everyone agrees that this is like a really good way to do it kind of scheme. So a few like examples of what that could look like are capitation. So capitation is when a hospital or a doctor or some other kind of medical firm gets paid based on the number of people that are enrolled in the healthcare like in the healthcare providers like service, or the insurance companies, or the insurance company that goes to that doctor. So they're going to figure out on average of the people subscribed to get service at this hospital, the cost per person is going to be X amount, and we're going to pay you the total of what that is. And if you want to use that money to if you can find ways to cut down the money per patient that would be expected for you to treat that condition, then you get an incentive for being a more efficient, for having a more efficient use of resources. You would have a financial incentive to not order unnecessary tests because those cost you money that you would not be directly reimbursed for. Global budgeting is largely the same thing, except in terms of the hospital as a whole, in terms not just how individual, not just in terms of treatment, but in terms of them paying for their facilities as well, them getting an X amount of money and being able to use that money throughout their hospital. There are also two different kinds of capitation. One of them involves that kind of global system. I'm actually going to stop there. It's okay. The last thing I wanted to mention was all payer rate setting, which I think I've mentioned a couple times before, that when you have an illness or get an injury, you need treatment, the amount that you pay to your doctor doesn't have to be the same as someone else that pays, sorry, let me back up. The amount that the amount that your insurance company pays to your doctor for that service is not the same as another insurance company paying for that doctor. So each insurance company negotiates with each doctor or hospital how much they're going to pay for a certain service, which to me doesn't really make a lot of sense, because if two people have the same injury, why are they paying different amounts for it? So all payer rate setting is a system in which all of those costs are the same. And this is actually the system that Maryland has put in place, which, as I mentioned before, on the kind of administrative section, can really cut down on trying to pour through all of the different rates for different things going on. Just be like, you can very easily look up, this person needed a cast for their broken arm, it costs this much. I don't know, something like that. Okay, that's it for me. I'm going to switch back to, I'm going to turn my screen share off.
What'd you say, Tyler? Oh, you're just switching back?
Yeah.
Okay. Do you have more?
No, I mean, I'm good for questions or anything, but yeah, that's it.
Okay. Well, if there are any questions, you all can be back in your morning lab sessions at 11:10. But if you have questions, you can stick around and ask Tyler. Okay.
Well, it must have been super informative because there's no questions. Amazing.
Hey, I paused in the middle for questions before, so I already got those.
That wasn't shade at you. That really was not shade. It must have been really well done.
Okay, so when I clicked the thing to open this lecture, it said I'm going to be talking about the 2019 Medicare for All bill, which I definitely really did not do. I just talked about Medicare for All generally. So I didn't really know.
I think that's fine.
I hope it was
don't really
okay.
think it's about. I'm sure it was. I don't really think it's about the bill. I think the debates will be largely just about like healthcare in general, to be really honest. So.
Okay. Hope so.
The bill is super vague too, so you pretty much covered what the bill is.